So now let's talk about the surface anatomy of the lungs itself. Where are the lungs in a patient? So, firstly, let's recognize that we know that the left lung has 2 lobes and the right lung has 3 lobes. On the left side, there's an oblique fissure separating the 2 lobes. On the right side, in addition to the oblique fissure, there is a horizontal fissure. So the first point I want to make, let's look at the left lung, where we just have an oblique fissure. Notice that even though we say that the oblique fissure separates the upper lobe from the lower lobe, or superior from inferior lobe, notice that what we're calling the upper or superior lobe is not really superior, it's not really upper. It goes from the top of the lung all the way to the bottom of the lung. So superior is not a very good name for it. A better name would actually be anterior, because it is, in fact, anterior. But it's not called that, it's called the superior lobe. And similarly, what we call the lower lobe is not really so much lower as it is posterior. It goes from the bottom of the lung, almost, not quite, but almost to the top of the lung. You can't, if you turn this around so you can see the back of the patient, you would see it goes almost to the top. So the point here is that because the oblique fissure is oblique, what we call the upper lobe is really anterior, what we call the lower lobe is really posterior, which means if you're going to be auscultating the upper lobe, you need to be doing that on the anterior chest wall. If you're auscultating the lower lobe, you need to be doing that on the posterior chest wall. And that's similarly true on the right lung. So oblique fissure is pretty much the same. But on the right lung, because we also have a middle lobe, the middle lobe is also anterior. You can sort of separate off the middle lobe as if it were part of the upper lobe below the horizontal fissure. Okay? So that's the first point. Upper lobe is anterior, lower lobe is posterior. Now let's get a little bit more specific about where these lobes and fissures are. Where the lobes and fissures are. So let's start with the fissures. Since the lobes are defined by the fissures, what we want to pay attention to is where are the fissures? Where are the fissures? So, the oblique fissure first. The oblique fissure is pretty much the same on the right and the left. It is roughly parallel, not perfectly parallel, but close, almost parallel with the fifth intercostal space. So remember, the ribs are oblique, therefore the intercostal spaces are oblique. And so it's not a surprise that the oblique fissure follows the course of an intercostal space. Okay, so that's the oblique fissure. The horizontal fissure, which is only found on the right side, is horizontal. That's why it's called the horizontal fissure. But because it's horizontal, but the ribs and intercostal spaces are oblique, as you follow that horizontal fissure laterally from its origin, we see it will cross more than one rib. So the horizontal fissure starts at the fourth costal cartilage, next to the sternum, fourth costal cartilage, and then as we head horizontally to the right, goes from the fourth costal cartilage to the fourth intercostal space, to the fifth rib, to the fifth intercostal space. And then, of course, the fifth intercostal space is where the oblique fissure is, so that's where the horizontal fissure meets the oblique fissure. Okay? So that tells us where the fissures are on a patient. And since the lobes are defined by the fissures, we automatically know where the lobes are. So for the left lung, where we only have an upper and lower lobe separated by the oblique fissure, since the oblique fissure is the fifth intercostal space, the left upper lobe is above the fifth rib, the left lower lobe is below the sixth rib. Okay? That's pretty easy. And then for the right lung, since we now have to account for the horizontal fissure, and since the horizontal fissure is where we said from the fourth intercostal space out to the fifth, from the fourth rib to the fifth intercostal space, on the right side, the middle lobe, which is between the horizontal and oblique fissure, the middle lobe is between the fourth and sixth ribs. The upper lobe is above the fourth rib, in other words, above the horizontal fissure. And the lower lobe is still below the oblique fissure, so it's below the sixth rib. Okay? So this is information that you would need. One of the question types that you often will see on the exam are what are called the penetrating wound questions, where the vignette describes a patient who arrives with a penetrating wound of some sort, a knife blade or something like that, and they'll tell you where the wound is on the chest wall or the abdominal wall, and they'll ask you what organ or what part of what organ is most likely to be injured. So if you were to be told about a patient who had a penetrating wound in, let's say, the right fourth intercostal space, 2 inches away from the sternum, what part of what organ would be injured? Well, if it's in the fourth intercostal space on the right, that means it's below the fourth rib, and below the fourth rib, but above the sixth rib, that would make it the right middle lobe. If that wound was in the third intercostal space on the right, then it would be the upper lobe, and so forth. Okay? Okay, just very briefly, just one word about lymphatics from the lung. Lung cancer most frequently will metastasize by way of lymphatics, so we need to know about lymphatic drainage. And simply put, there's a whole series of nodes. We start off with what are called pulmonary nodes within the lung itself. They drain toward the hilus of the lung, right around the hilus. There are what are called the hilar nodes or the bronchopulmonary nodes. They eventually drain to the nodes along the trachea, tracheobronchial nodes, and then they run up along the trachea as paratracheal nodes. And eventually will drain into the venous system on the right and left sides, respectively, through the mediastinal trunks, lymphatic trunks, into the venous system on the left and right side, respectively. Okay, and that's all we really need to say about that. Let's now turn our attention to the histology of the respiratory system, and let's first start off by understanding the parts of the respiratory system. We can divide the respiratory system into two large categories. Part that is in fact the respiratory portion, and the part that is the conducting portion. By the respiratory portion, I mean the part of the system in which gas transfer actually occurs, where oxygen is being moved from the air into the bloodstream. That occurs only one place, in the alveoli, in the lungs. So that's the business end of the respiratory system. All of the rest of the respiratory system has as its major function moving the air from the outside world to the alveoli. So it's basically a conducting portion. There is no gas exchange occurring. But what is occurring is as the air is moving to and from the alveoli, it's passing over surfaces where we're going to have some filtration, we're going to have some filtering, moistening rather. So we're going to be doing things to the air, but we're not going to be exchanging gas. So it's really just a conducting portion. So the conducting portion of the respiratory system would begin in the nasal cavity. Right? So the nasal cavity and the oral cavity leads back into the pharynx, nasopharynx and oropharynx, which then leads down into the larynx, through the larynx, into the trachea, from the trachea to the bronchi, to the segmental lobar and segmental bronchi, to the bronchioles, and eventually, finally, to the alveoli. And it's not until the air gets to the alveoli that the business of respiration really occurs, the gas exchange. So we need to think about what kind of histology would support those functions. Gas exchange in the alveolar region and moistening and filtering in the conducting portion. That's what we want to pay attention to. So let's start off with the nasal cavity. Firstly, recognize that in the nasal cavity, we have another important function that goes on there in addition to the conduction of air, that's olfaction. So there is a portion of the nasal cavity devoted to the olfactory sensation, and that's just the upper portion of the nasal cavity, the roof of the nasal cavity and the upper part of the medial lateral wall. So there the mucosa is different. It's modified into what's called olfactory mucosa and has specialized receptors for olfaction. So we're not going to worry about that. We'll leave that for neuroscience. All of the rest of the nasal cavity is what's called the respiratory portion, and the mucosa that we're going to see there will be the typical respiratory mucosa, and we'll talk about what that looks like in just a few minutes. And we would expect to see exactly the same thing in these portions, the nasopharynx, the oropharynx, those would all be respiratory mucosa. Okay, similarly down through the trachea, through most of the trachea, and the bronchi and so forth. Okay? So, let's think this through. If you think about the respiratory system, we're going from the upper portion, which is the conducting portion, to the lowermost portion, which is the respiratory portion, the alveoli. What would we expect in terms of cell types? So let's start off with the epithelium, which we said is the business part of most organs, the epithelium. Because gas exchange is occurring in the alveoli, the lowest part, not even shown on this chart, it would be further to the right. That's where gas exchange is occurring. We would want to have an epithelium that's extremely thin to facilitate gas exchange. Remember, the thinnest kind of epithelium we can have is simple squamous epithelium. So we would expect to have a simple squamous epithelium when we get down to the alveoli. At the upper end of the conducting portion, up in the trachea, as well as above that in the nasal cavity, we would have sort of the characteristic respiratory epithelium, which we said earlier is the pseudostratified ciliated columnar epithelium with goblet cells. So let's talk about that for a second. Why ciliated? Why is it ciliated, and why goblet cells? Well, the goblet cells in this conducting portion of the respiratory system, the goblet cells secrete mucus. We want to have mucus in order for it to trap foreign particulate matter that's in the air. We want to try to get as much of that out as possible before the air gets down to the alveoli. So we coat the conducting portion of the respiratory system with mucus, largely coming from goblet cells, and then we want to be able to move that mucus up out of the respiratory pathway, up into the pharynx so we can then swallow it. So we use the cilia. Remember, the cilia have microtubules in it, so that they beat, so that they will move the mucus upward. So if we're going to have goblet cells secreting mucus, we better have cilia on the epithelia to move that mucus. So that's what we would expect to find. But let's follow our logic through this. So here we have a pseudostratified columnar epithelium, which means it's a relatively thick epithelium. Down in the alveoli, we said we're going to have a simple squamous epithelium, a very, very thin epithelium. Well, logic would dictate that it's not going to suddenly change from fairly thick to very thin, like at one particular line. It's not going to suddenly change. You'd expect that there's going to be a transitioning from a thicker to a thinner to a thinner to a thinner to a thinnest epithelium. And so that's exactly what we see. As we work our way down the conducting portion of the airway, we go from a pseudostratified ciliated columnar epithelium to a simple columnar epithelium. And as we keep going down, it'll actually become simple cuboidal until finally it becomes simple squamous. So the epithelial cells layer epithelium becomes thinner and thinner and thinner until finally we're at the simple squamous where we have gas exchange. Okay? I think that makes sense when you think about it. Let's jump down here to glands. We said that we want glands to secrete mucus. So we have the goblet cells, we have mucus glands. And we said that we want that mucus to coat the airway in order to trap foreign particulate matter. We certainly don't want to have mucus down where we want gas exchange, because coating the alveoli with mucus would certainly interfere with gas exchange. So you don't want mucus down there. By the time the air is down there, it should have already been filtered, so you don't want mucus. So you want lots of mucus glands at the upper end, you want no mucus glands at the lower end, and so you would expect, again, to see a gradient of fewer and fewer and fewer until at the lower end you don't have mucus glands. Okay? What about rigidity versus elasticity? We want the upper end of the airway to be rigid so that during expiration the lumen doesn't collapse, and so we're going to give it rigidity by putting cartilaginous rings in it. Once we get down to the lower end, once we're inside the lung, we know that the lung has to expand and contract during the respiratory cycle, so we certainly don't want rigidity there. And so we're going to go from having lots of rigidity at the upper end to having no rigidity at the lower end. So again, you're going to go from having C-shaped cartilages to discontinuous cartilage to less and less cartilage until finally no cartilage. So as we go from top to bottom, we are losing cartilage, we're losing mucus glands, but sort of the inverse of the cartilage, as we're losing rigidity, we want to gain elasticity. And so as we're decreasing cartilage, we're increasing elastic fibers and smooth muscle. Okay, so that increases as we go down, that decreases as we go down, that decreases as we go down. Okay? So always try to associate histology with function, and you'll see that it makes sense. So here we're looking at some examples of what we just talked about. So here's the upper end of the trachea, then the bronchus, then the bronchioles. So rigidity, cartilage, continuous C-shaped cartilage at the upper end, no cartilage at the lower end, intermediate, in other words, interrupted plates of cartilage in the middle. Okay? As we're losing cartilage, we're gaining smooth muscle and elastic fibers. So let's take a look at what that looks like histologically. So here we're looking at the trachea, and it's got several layers. It's got an innermost layer, which is the mucosa, and then outside of that there's a submucosa, which contains connective tissue and blood vessels. Outside of that we'll have a muscular layer and or cartilage, depending upon where we are. So here we see cartilage in this part, smooth muscle in this part. And then outside of that, we have the connective tissue, adventitial layer. So mucosa, submucosa, muscularis and or cartilage, and then adventitia. There's the lumen in there. So let's take a look at the epithelial lining of the mucosa. So the epithelial lining is going to have a pseudostratified columnar epithelium. Right? We've already said that. It's going to have goblet cells. Submucosa will have connective tissue. Okay, and blood vessels. And then the outside covering is connective tissue of the adventitia. So let's look at that in higher power. So here is the epithelial layer of the mucosa. Here's the lumen of the airway. So what we see for the epithelium is that typical pseudostratified columnar epithelium. Looks like multiple layers, but we know it's really all those cells are reaching the basement membrane. And we see that those cells are ciliated. Right? It's ciliated. Remember, the cilia are there to move the mucus that's being secreted by these mucus-secreting cells. Those are goblet cells. So incorporated within the epithelium of the trachea, we have these goblet cells, which always look sort of pale because the preparation that washes out the mucus, so they end up being very pale stained. Okay, so that's the mucosa of that's the epithelium of the trachea. Remember, any place where you have an epithelium, you're going to expect to see stem cells. So you'll recognize stem cells because you'll see mitotic figures in there. Okay, and remember we talked about the significance of the loss of motility of the cilia in primary ciliary dyskinesia or cardiogenic syndrome, where they will interfere with the ability to clear mucus. We also talked about the role of the chloride pump of the epithelial cells in pumping water into the lumen in order to mix with the mucus to make it a less viscous substance. So in cystic fibrosis, since you have the mucus secreting cells with less water being pumped in, the coating becomes more viscous. Moving down the airway to a bronchus, one of the things we see that's different is instead of seeing a C-shaped continuous cartilaginous ring, we see discontinuous cartilage. So here's a plate of cartilage here, there's a plate of cartilage there, but there's no cartilage there, there's no cartilage there. Okay. We still have the same respiratory epithelium lining the lumen, pseudostratified columnar epithelium, that hasn't changed. Okay. And we have the addition of other cell types associated with the neuroendocrine system and the immune system. Any place where our body is in contact with the environment, whether it be the respiratory system or the alimentary canal, if we're bringing the external environment into the body, you're going to expect to see components of the immune system present in order to protect us from the pathogenic elements of the environment. When we work our way down into the lung now, we're down to the level of the bronchioles, no more cartilage. The epithelium has become much thinner. So instead of it being pseudostratified columnar, it's a simple columnar, a simple cuboidal at this level, simple cuboidal. And there are no glands, because we certainly don't want mucus down here that would interfere with the ability to have gas go across the alveolar membrane. So there's no mucus, but lots of elastic fibers. Okay. There are a special cell type found in the bronchioles, which are illustrated here, that you can recognize them. They sort of bulge out into the lumen of the bronchiole. Those are called Clara cells, or bronchiolar secretory cells. They secrete a substance similar to surfactant. Surfactant is actually secreted in the alveoli, but this is similar to surfactant and serves a similar function, which is to reduce surface tension. Recognize two major diseases of the airway that you need to be aware of is COPD. COPD is a category of diseases which would include emphysema and asthma. Keep in mind that asthma is generally an inflammatory process, is reversible. Emphysema is a breakdown of elastic fibers and is not reversible. Let's work our way down now to the alveoli, which is really the business end of the entire respiratory system. So in the alveolus, that's where we get gas transfer from the air to the bloodstream. So in the alveolus, we would expect to see a very thin epithelial layer. And so remember, very thin epithelium is going to be a simple squamous epithelium. So that's what we see here, lining the alveolus. There's the airspace in the alveolus. Abutted right up against that, we're going to see a blood vessel, a capillary. Again, a very thin epithelium. Again, simple squamous epithelium lining the lumen of the capillary. Here, when a simple squamous epithelium is lining a blood vessel, you call it endothelium, but it's just another name for a simple squamous epithelium. So you have a simple squamous epithelial cell there, you have a simple squamous epithelial cell there, and in between you have a basement membrane. That's the entire barrier between the air and the blood. So that's what we see magnified here. Okay? The alveolar epithelium, the capillary epithelium, basement membrane in between. Air is there, blood is there. Okay? Now, in addition to these very thin epithelial cells, thin squamous epithelial cells, which are called type 1 pneumocytes, we have these other epithelial cells here that are not nearly so thin. They're really quite thick. Okay? They're really quite thick. They're called type 2 pneumocytes. Type 2 pneumocytes. And type 2 pneumocytes have two important functions. One is they are stem cells. So type 2 pneumocytes are mitotically active. They divide, giving rise to more of themselves, as well as giving rise to cells that will differentiate into type 1 pneumocytes. So type 1 pneumocytes come from type 2 pneumocytes. That's the source of the cells as these wear out and get replaced. And the other important role for type 2 pneumocytes is they secrete surfactants. So we'll find secretory vesicles in there, and surfactant is the substance that reduces surface tension in the alveoli in order so that the alveoli don't collapse upon themselves during expiration. Okay? Recognize that actually there are more type 2 pneumocytes than there are type 1 pneumocytes, but because type 1 pneumocytes are so thin and attenuated that most of the surface area of an alveolus is lined by a type 1 pneumocyte, with a very limited amount of the surface area accounted for by type 2 pneumocytes, but there are more of these, they just don't cover as much surface area. And type 2 pneumocytes, again, serve as stem cells for type 1 pneumocytes. So here's a histological section through a group of alveoli. So here's the airspace. There are our type 1 pneumocytes. These larger ones are type 2 pneumocytes. There and there. Remember, those are the ones that are going to be secreting surfactant. Okay? There are also present, at the level of the alveolus, there are also present macrophages. So remember, we have had lots of mechanisms for filtering the air before it ever gets to the alveolus, right? We have mucus, we have cilia, they're all the way at the top of the nasal cavity. You actually have hairs. All of these are designed for filtering out particulate material in the air before it gets to the alveolus. But it's not a perfect system, and there is still some material that's still in the air that gets down into the alveolus. And so that material has to be phagocytized by elements of the immune system that are in the lung. So there are macrophages in the lung that are mobile. They're able to actually be in the alveolus and phagocytize particulate matter, and they migrate out of the alveolus into the interstitium, into the connective tissue between the alveoli. And those macrophages that are there to phagocytize particulate material in the air that has reached the alveolus are called dust cells. Dust cells because fundamentally what they are phagocytizing is components of dust. Okay? Remember that the type 2 pneumocytes are secreting surfactant, but that secretion of surfactant is really not adequate until quite late in gestation, and that's why in preterm babies they are subject to respiratory distress syndrome because of the inadequacy of surfactant secretion by type 2. And we talked about the two layers of epithelium with a basement membrane in between, serving as the blood-gas barrier. There are openings between alveoli called the pores of Kohn. Pores of Kohn. There are openings between alveoli that allow for collateral ventilation in the event of obstructions of the airway. Okay? It also allows for those macrophages to move from one alveolus to another. So what we hope to accomplish in this portion was to identify the anatomy of the chest wall. We talked about the breast and the anatomy of the lungs. We wanted to understand the embryonic development of the lungs and the pleura, as well as the adult anatomy, and to understand the structural and functional correlates in the histology between the upper and lower portions of the respiratory system.